We have 4 talks in this session, ending at 12:15 prior to lunch. And they're from speakers from all over the world. The first speaker is Charles Cock from Adelaide, Australia. Charles is going to talk about neuromyogenic disease, and it's definitely going to hopefully have some HRM in it. Thank you, Charles.
Thank you very much for that introduction. Tim, thank you for the invitation. It is fantastic being here in Ascona with all of you. It's a beautiful day outside. When I got into taxi to drive to the airport in Adelaide, it was a beautiful day as well. And I said to the taxi driver, "It's a beautiful day," and he said, "Sir, every day is a beautiful day." So I think that's a lesson for all of us that are privileged enough to sit here today. So I'm going to talk about neuromyogenic disease or neuromuscular swallowing disorders, and you may ask yourself the same question I asked myself when I was coming up here today, which is why is a gastroenterologist and perhaps not a neurologist giving a talk on neuromyogenic disease? So when I moved to Australia, I worked in a veterans hospital, and I found out very quickly that older patients have lots of issues with oropharyngeal swallowing disorders. And in my training in gastroenterology, I didn't have a lot of training. I think there was a few throwaway lines about nasal regurgitation and coughing and choking during swallowing, and that was about the extent of training that I received in oropharyngeal swallowing. So it is something I've learned a little bit about, mainly from the speech pathologists that I work with in the hospitals where I work, but also from a wonderful team around me, some of whom are here. So I have no commercial conflicts of interest. So neuromuscular swallowing disorders, just a brief introduction. I've already said the majority of causes of oropharyngeal dysphagia, things like stroke, neurodegenerative diseases, myopathies are in this category. And there's a fairly simple schema of neural inputs, as you can see here. So this is from Pere's recent publication in dysphagia on the brain and pharyngeal responses associated with pharmacological treatments for oropharyngeal dysphagia. So what this slide partly demonstrates is that there's a complex interplay of motor pathways, of sensory pathways, of reflex pathways with sensory inputs from the oropharynx itself into the brainstem, into this conceptual swallowing pattern generator. So there are motor inputs into the nucleus tractus solitarius, and there are motor outputs from numerous motor neurons, and this all has to be coordinated with breathing. So the whole swallowing mechanism originates mainly in the brainstem, but it is modulated for volume and it's modulated for consistency by inputs from the oropharynx and possibly other inputs, possibly from the proximal esophagus. There certainly are feedback mechanisms, and you can see there are numerous motor outputs. And here are some pictures of the musculature in the pharynx. And you can see that there's a large number of muscles involved. Certainly the tongue is one of the most important originators of pharyngeal bolus propulsion. Some studies from the 50s show that you can possibly live without your anterior tongue, but not so much without your posterior tongue. So the posterior tongue is really important in bolus propulsion from the pharynx into the proximal esophagus. And then there are numerous muscles that are involved not only in pharyngeal constriction, like the pharyngeal constrictors, but also in elevation of the hyolarynx. So all of which is important in the pharyngeal swallowing mechanism. So we've got this complex interplay of neural and muscular mechanisms. We've got inhibition, we've got excitation, all of which is involved. I would say it's more complex than the mechanisms in the esophagus, and most of this is striated muscle, of course. So the initiation of swallowing is under volitional control, but swallowing in the pharynx is possible in decerebrate animals. So you can trigger a swallow in your pharynx that will propel the bolus without inputs from your central nervous system. So that's it, a whole complex interplay of factors. We don't not only need the propulsion, we need all of the escape routes, if you like, sealed. In particular, the important one down the airway, but also the nasopharynx. So I'll just show you some radiological correlates. So now we're going from the swallowing function to measuring it, and radiology was certainly very important. I'll make this a bit bigger. So here we can see what's typically looked at on video fluoroscopic swallowing studies. We can see examples of the valleculae, of the piriform sinuses, both in the lateral view, but also here in the AP view, and you can see that there's some bolus residue. So what's the purpose of all of this? So what is oropharyngeal swallowing function? So distinct from the motor function, the job of oropharyngeal swallowing is to safely and effectively propel the bolus from the oropharynx into the esophagus. So here we can see an example where that's not occurring. So there's impairment of swallowing safety. I might take that back and you can watch it again. So you can see impairment of swallowing safety. You can see airway soiling occurring, or aspiration. And you can also see post-swallow residue. So those are what we would refer to as the outcomes. So the outcomes of this is aspiration and residue. And we had 3 beautiful talks where in the last talk by Natalie, she related the metrics we were interested in looking at as, if you like, physiologists, to clinical outcomes, which are, in this case, most importantly, aspiration and residue. So we spoke about video fluoroscopy or video manometry, of which this is an example. And Taher very nicely showed you that you can correlate a lot of the radiological measures with impedance-based measures. So you can, if you like, measure the same kind of things. One of the biggest issues we have as clinicians these days is getting into the fluoroscopy suite. It's often being used by interventional radiologists who are very keen to do lots of interesting things with and to people using the video fluoroscopic facilities. So it is getting harder to get in there, and yeah, I think that's just the reality of it, that we have to some degree accept. So we may have to look at separate measurements, but I think one of the things that we just had a chat outside there, and one of the things I said is these are all pieces of the puzzle, if you like. So all of the tests that we do add up to a whole, to a clinical picture, and at the center of it is the patient, and what is important is the the outcomes for the patient. So we have to start working towards generating data that tell us about patient outcomes. And I think that's partly what this session is about. So the outcomes, in crude terms, are aspiration and residue, but we're certainly interested in the mechanisms or the biomechanics underlying those outcomes. So whether that's upper esophageal sphincter flow restriction, which is an important mechanism in the oropharynx, whether that's propulsive failure, whether that's mistiming, or combinations of the above. And it does become a bit trickier when you start getting combinations. So then it's the picture isn't quite as clear, and that might be what's causing some of the confusion. And then we really want to move towards measuring the response to interventions, which might be medical treatments, it might be swallowing rehabilitation, it might be surgical interventions or endoscopic interventions. So I think that that's really where we need to be heading with this work in the next phase. So I'm just going to try and give you a little bit of context on measuring oropharyngeal swallowing function using manometry. So maybe a few caveats. So I will say that using bolus volume and consistency in assessing swallowing function is really critical in this area. You can use single volume boluses, but I'll show you some examples of where you really get more granular information by using different volumes and consistencies. And I did tell you that the swallowing system is really well tuned to accommodate a bolus of a specific volume and consistency. So both propulsively, but also upper esophageal sphincter opening. And this is one example. You'll see something similar later. But what you can see in this example, so this is a patient with Parkinson's disease that Peter Wu and McCullough studied. And what you can see is on the graphs on the extreme right, we've got different measures of upper esophageal sphincter function, and we've got the normal values are depicted by the dark lines. And with the red lines, what you can see is at a low volume, some of these metrics are normal, but if you push up the volume, the metrics become abnormal. So I think that this is really relevant, particularly in the context of neuromuscular swallowing function. Second area of complexity is a lot of these disorders occur in older patients. I know that people don't want to admit that there are issues when you get older, but certainly I had another conversation this morning. Someone told me all my old patients have difficulty swallowing their tablets. And I said, I think I know why. So because the tablets are too big, of course. That's the main issue. But here we can see these are healthy volunteers. It's just a little experiment we did, and we gave them volumes, and we just asked them to try and swallow it in a single swallow. And the younger controls could do it quite easily, whereas older patients, as soon as you get above 20 milliliters, so when you go to 30 milliliters, hardly any of them could swallow 30 milliliters in a single swallow. So that's part of the reason why they eat and drink slower, because essentially it's got to do with the fact that the upper esophageal sphincter doesn't open to the same extent because of fibrosis and neuromuscular mechanisms. And there is compensation for that up to a point, but none of the studies that were presented studied patients over 80 years of age, and there may be a point above 80 years of age where the compensation may fail, so, which I possibly will show you later. This concept of a dysphagia limit I find quite useful. So that's the volume that can be safely and comfortably swallowed in a single swallow. And it's derived from a lot of the Erdogan and colleagues' works in Turkey using electromyography in swallowing. And what they showed was that in patients with neuromyogenic causes, if this is a normal volume, if you like, that can be swallowed in a single swallow, you can see there's a very marked reduction. Here are motor neuron disease patients. So they start the study, and then subsequently there's a further reduction. So as the study goes on, they're less and less able to swallow larger volumes. Stroke patients rehabilitate to some degree, and they improve. And here's a group of I think it's polymyositis, and certainly with treatment, so steroids might be an effective treatment, you can see how the volume that they can swallow in a single swallow increases. So that concept I find useful. Another concept we have to be aware of is the concept of variability. So swallowing variability, which is not necessarily normally distributed. So an individual person, or certainly a group of individuals, will display different pharyngeal contractile patterns over time, or with different volumes, etc. So this is per volume, per specific volume in this study, but you can see from the Milwaukee group there that there's a non-normal distribution. The other study is just some unpublished data on paired studies in what I call younger and older patients. The younger patients were 21 to 73 at the start of the study. We studied most of them approximately 5 years later, so the average or the sort of median interval in the study was about 3 to 5 years. And then we repeated the study. So you can see that for this composite measure, the younger patients stayed within what we would regard a normal range, whereas particularly older patients over 80 years of age, when they start getting older than 85, we can see biomechanics in keeping with unsafe swallowing or aspiration risk. And there have been numerous studies, particularly from Barcelona, that looked at aspiration in community-dwelling healthy older people and showed increased rates of pneumonia, community-acquired pneumonia, which likely is aspiration pneumonia in this context. So we have to remember that neuromyogenic swallowing dysfunction often occurs on this background. And with any sort of manometry, the one thing that I'm really wary of when I'm reporting this clinically is overinterpretation. So I'm really reticent to call something upper esophageal sphincter dysfunction, or because I know when I call it that, the knife comes out and it gets sliced. So I think that's we have to be really wary, particularly in these early stages of development of high resolution pharyngeal manometry. We have to do the studies and the experiments around the treatments, and preferably in randomized controlled fashion, so that we can generate the data to guide future treatments. So I'm going to show you very briefly some examples from our clinic. So this is a real patient that I saw recently, 76-year-old man with dysphagia and weight loss. I think he'd seen 3 gastroenterologists by the time I saw him. Food avoidance, multiple specialists. They finally managed to do a manometry and diagnose him as ineffective esophageal motility, and you can see the distal esophageal contraction here. You can't really see proximal esophageal contraction, which he's missing. But despite this, and despite having really weak contractions, his bolus transit through the esophagus actually wasn't too bad. But he then developed a voice disturbance and muscle weakness, and got referred to the ENT surgeons, speech pathologist, and then to a neurologist, and he was diagnosed as likely motor neuron disease. So which would fit with a lot of his symptoms, particular changes in his voice and swallowing. And I work in the multidisciplinary swallowing disorders clinic, see lots of patients with motor neuron disease in that context. But something about this guy just didn't fit the usual pattern, so I decided to do a pharyngeal manometry on him, and that was what we found. So that's the so qualitatively, just to walk you through this. So this swallow on the left here is a normal swallow. I know that because it happens to be my own, and this, what you can see here is really qualitatively, you can see a really weak contraction. So for me, this is a pattern that fits with something like a myopathy. Certainly you can see it in motor neuron disease, but I want to rule out a myopathy in this kind of context. And we sent him for we did serology for every myositis test that we could. And we then did a muscle biopsy, and he's got inclusion body myositis. So the relevance, I guess, for him is that there possibly there is some evidence that things like interventions addressing the upper esophageal sphincter might be quite useful in a group of inclusion body myositis. So just as a, if you like, a phenotype, or archetypical failed pharyngeal propulsion, all of these metrics are low. The US opening extent is very often reduced, but because the pharynx is not generating enough pressure, you can't measure increased intrabolus pressures, which is usually the measure that we use to determine. And again, Ian Cook, McCullough, Peter showed very nicely that you need a propulsion above approximately 60 millimeters of mercury in the hypopharynx. I think it was 57 is the exact number, to be able to generate an intrabolus pressure that will tell you that the patient's got US obstruction or restriction. So in this context, I often see lots of residue, in particular when the consistency increases and we see an increased aspiration risk. So here's another clinical example. This is a very interesting gentleman, Mr. Gigi, who had a brainstem stroke with lateral medullary syndrome, and what you can see here is probably intrabolus pressure being generated, so that pan-pressurization we spoke about earlier. In this case, you can see the metrics associated. The US IRP is 36 millimeters of mercury, and intrabolus pressure is 44, so those are quite high. This very interesting gentleman who couldn't swallow his saliva, but managed to walk down to the hospital shop and buy a canister of flavored milk and gave himself an aspiration pneumonia. So he was peg fed for a while, and we managed with upper esophageal sphincter dilatations and swallowing rehabilitation to get him swelling well enough to be able to remove the peg. I'll show you this example before. So this is a patient with Parkinson's disease, where you can only see the dysfunction with increased bolus volumes. And really this is something that we do see in patients with Parkinson's disease, that they have evidence of upper esophageal sphincter dysphagia. So archetypical US dysfunction, a high IRP, a high IBP, if there's pharyngeal pressurizations, and a reduced extent of US opening, however you measure that, and particularly increased aspiration risk, because the bolus has to go somewhere. It's not going through the US, so it's going into the lungs, and some examples of that would be lateral medullary syndrome, Parkinson's, inclusion body myositis, and some motor neuron disease patients. Now, on motor neuron disease, here are 4 different patients all with motor neuron disease. So I'll just show you the comparison again, normal, because the patient on the left is quite near normal. So this example, but you can see there's all kinds of different patterns occurring in motor neuron disease, and lots of different abnormalities. So the patient on the left is near normal through measurements, and here we can see the outcome measures. These are not all included in the published data set of outcome measures, but this is a measure for aspiration, which is much higher in motor neuron disease. This is a measure for post-swallow residue, which is much higher in motor neuron disease. And this is the extent of upper esophageal sphincter opening, which is much lower in motor neuron disease. So those are some of the abnormalities you can potentially determine using manometry. So we do see these conditions like motor neuron disease and hemispheric strokes where you can get a combination of abnormalities, commonly with regional weaknesses or panpharyngeal weakness, variable upper esophageal sphincter disorders, mistiming of swallowing, and often an inability to adapt to volume viscosity changes with aspiration and residue, and that might be indicative of sensory dysfunction. So, in summary, neuromyogenic diseases are often oropharyngeal, a cause of oropharyngeal swallowing disorders often occur in older patients. The use of different volumes and viscosity is critical in assessing impairment. High-resolution pharyngeal manometry with or without impedance complements existing diagnostic techniques. There are some arch types you can describe, and this article will inform you a bit more on some of the diagnostic categories that we can look at. So what we need next are RCTs of novel medical approaches, targeted swallowing rehabilitation, and endoscopic and surgical interventions. Thank you.
Mark's going to want us to move along, but maybe we have time for one question while our next speaker is coming up. And
Charles,
Pierre.
I mean, I really enjoy that kind of bringing together of physiology and clinical work. We've seen a lot about UES opening. I mean, if the door's closed, then you can push as hard as you like and it's not going to open. But it is true, as a non-UES specialist, that it is actually an active process, isn't it? It is not just a passive opening process. It's actually elevated and pulled open. And
Yeah.
is that why MND has such profound effects?
So it's US opening is a whole topic on its own. Maybe Peter can come and give the talk to us, but essentially it has to relax, so it has to deactivate and relax, and then there's hyolaryngeal elevation, and that I agree. I think in motor neuron disease that part is impaired, so that you don't get the distraction and the relaxation as a consequence of distraction. Thank you.
Thank you.
It's a pleasure to invite the next speaker, Pere Clave, who will be talking to advances in the management of oropharyngeal dysphagia.
First of all, thank you, Mar, for this very nice invitation to attend this so exciting meeting. My name is Pere Clave. I'm Sergeant by Education. I'm Director of Research and Innovation at my hospital. I am the founding president of the European Society for Swallowing Disorders. That's a view of my hospital that is in Mataro, a city 35 kilometers north Barcelona in Catalonia that is affiliated to the Autonomous University of Barcelona and also to a national research consortium that is called Cyberhead. And this is the outline on advances in management of oropharyngeal dysphagia. I will present you our tool for massive screening of oropharyngeal dysphagia with artificial intelligence and machine learning. I will discuss with you new metrics for the biomechanics, video fluoroscopy and spontaneous swallowing frequency, and neurophysiology, mainly pharyngeal and motor, pharyngeal sensory and motor evoked potentials of swallow response. I will present you new evidence from our group on the therapeutic effect of a new family on xanthine gum thickening agents that are very useful to compensate aspiration in those patients. And we will move from compensation to the recovery of the swallowing function through pharmacological treatment of dysphagia with TRP agonists to promote the recovery of brain and swallowing function, and then some conclusions. As you know, oropharyngeal dysphagia is a clinical symptom, and patients are frequently unaware of their swallowing dysfunction. This dysfunction can include aspirations, and dysphagia is very well recognized by the World Health Organization and included in the International Classification of Diseases with specific codes. Oropharyngeal dysphagia has three main clinical characteristics. The first one is that, as you know, it's a highly prevalent condition among different phenotypes of patients, including the elderly, patients with neurological diseases, head and neck cancer, or even COVID-19 or cerebral palsy. It leads to very severe complications such as malnutrition, dehydration, aspiration pneumonia that is associated to very high mortality rates. And although this high prevalence and clinical severity of complications is not always systematically explored and detected, and we still do not have any pharmacological treatment. And today, more than 16 million US citizens, 30 million European citizens, and 8 million European citizens have oropharyngeal dysphagia. And I don't know you, but I promise you that 50% of you will have oropharyngeal dysphagia at 75 years. I don't know if this half or the other half, but sure, 50% of you. As you know, the diagnostic process for dysphagia has three main steps. The first one is a screening. It's a very slow process. We use questionnaires for screening. We spend minutes for every patient, but we have very nice tools. We also have very nice tools for clinical diagnosis. We have developed at our hospital the volume viscosity swallow test to explore for safety and efficacy of swallow. And as we have discovered this morning, we have fantastic tools for instrumental assessment. And I will add how beta-fluoroscopy, manometry, and also neurophysiology can add data to the picture to have robust metrics to understand the pathophysiology of the disease. Let's start with massive screening. As you can see, left column shows the usual state-of-the-art of screening. At our hospital, before we developed this system, we screened less than 20% of patients. The accuracy of our nurses was quite low, 55%. We spent, in theory, 62 hours to screen a hospital of 450 beds and only 7 patients by year. By using the algorithm I will present you, we now screen every morning all patients admitted at the hospital. The accuracy has been improved up to 85%. We screen all the patients in 6 seconds, and we can screen every year all the patients admitted at our institution. We do this through a systematic and universal intelligence screening method for oropharyngeal dysphagia, and we can even manage the risk to use that. We publish the methodology, and we compare a multivariate analysis of the data we use with machine learning, and machine learning beats the accuracy of the multivariate analysis, so it's much more accurate. How it works? Well, the idea is that the hospital that requests the service of mass screening just sends a question that can include up to 500 variables. In fact, we have even tested 25,000 variables, but sends a question without the identification of the patient. So we have a database with 9,000 people with the true having or not having oropharyngeal dysphagia and all their medical records during the last 10 years. And we can provide an answer classifying the risk for oropharyngeal dysphagia that can be shown in the workstation of nurses and healthcare practitioners at the hospital. By using this methodology, now the Catalan Health Service has helped us with a big grant to introduce this in 10 hospitals. So at the end of this year, we will screen every morning 2.5 million of patients that are admitted or in the influence area of those hospitals. That's the startup that we have founded to manage that. In patients with a positive screening, we claim for a clinical diagnosis. We use the VBST that we have developed in our team. It's a clinical method that uses speech and language therapists, nurses, specialized nurses. And it has, in a very recent review, very nice psychometrics, up to 93% sensitivity and also good specificity, a very nice reliability. That's a method that challenges the patients for safety and efficacy, and is also useful to select the optimal bolus, volume, and viscosity to provide a safe and efficient swallow in each patient. Apologize. Just to jump to the next slide. Okay. Well, in those patients with a positive test, we have discovered that we have complementary explorations to characterize the pathophysiology of the disease. We started at the hospital also to develop neuromyogenic metrics, and I will show you how, mainly measuring the pharyngeal sensory evoked potential and the pharyngeal motor evoked potential to transcranial magnetic stimulation. So we can be neuromuscular metrics that then will condition oropharyngeal biomechanics. We can measure timing, extent, strength, pressure, force, bolus velocity by using either manometry impedance or videofluoroscopy. And also these alterations in these biomechanical impairments will lead to impaired safety and efficacy signs, dynamic signs of swallow that are visual perceptual signs that will help us to make a diagnosis of the condition. So by combining the two first, we will understand the pathophysiology of the condition, and by combining those with the other ones, we can have a diagnosis of the impairment on safety and efficacy of swallow. Our gold standard for dysphagia at our hospital is videofluoroscopy, and we have developed robust metrics based in those described by Peter Carillas maybe 30 years ago. What we did is to refine the system to do this in a more automatic way, and we first explore the swallow response in healthy volunteers, and we discovered that the overall duration of the swallow response is very short, and it's increased by volume but unaffected by viscosity. But the most important part is that the reconfiguration phase, that is time from glossopalatal junction opening to laryngeal vestibule closure, is constant and very fast, as it takes less than 160 milliseconds to protect the airway. We also discover that the bolus propulsion forces are very strong, and the velocity of the follows in the pharynx is up to 31 centimeters per second, the highest bolus velocity throughout the intestinal tract. We also studied with this methodology what happened in patients with oropharyngeal dysphagia, and obviously we discovered that this overall duration of the swallow response was prolonged, but most important is the time to laryngeal vestibule closure was prolonged, and also the time to oropharyngeal sphincter opening. And this was related to aspiration, and weak bolus propulsion was related to low velocity in the pharynx, leading to very low bolus propulsion forces. For us, the most important point is that we discovered that delayed laryngeal vestibule closure predicts unsafe swallow and aspiration. We found that most patients with oropharyngeal dysphagia and unsafe swallow present a significant delay in laryngeal vestibule closure, and also that the cutoff time above 340 milliseconds predict aspiration or penetration. As an example, this is an aspiration during the swallow response associated to delayed laryngeal vestibule closure. The red point is the aspiration, the white one is the penetration, and this happens in up to 25% of patients with oropharyngeal dysphagia. In this particular case, is an older patient. We also discovered that weak bolus velocity and weak bolus propulsion forces predict pharyngeal residue, and that these measurements can be obtained by measuring bolus velocity prior to entering the upper esophageal sphincter, and also bolus kinetic energy. So that's the overall picture of the metrics that we use to characterize the swallow response in those patients. We also were involved in many studies trying to avoid aspiration on those patients. And one of the strategies that we follow is compensation using increases in shear viscosity. This is a study that we conduce by using a new shunt and gum thickening agent. As you know, there are two main families of thickening agents, one based on starch that are affected by amylase, so that they are quite dangerous. The second one is a new family of shunt and gum thickening agents that are unaffected by oral amylase. And what we discover is when we increase shear viscosity, and we measure this viscosity in international system of units, we discover a very nice viscosity-dependent increase on safety of swallow. We also discover that increasing viscosity slightly increase oral residue without affecting pharyngeal residue. And by converting these curves to logarithmic curves, we could measure that the therapeutic effect of these products is viscosity dependent, and there is a very narrow therapeutic range, meaning that the therapeutic effect on aspiration starts at 250 millipascals and leaves to 800 millipascals, meaning that even if you increase the viscosity above 800 millipascals, you will not increase the safety of swallow of those patients. As an example of the therapeutic effect of thickening agents, at your left, you will see an aspiration during the swallow response that is associated to Adelaide laryngeal vestibule closure. And just by increasing the viscosity to 250 millipascals, the aspiration is avoided. But if you see the chronogram, there are no changes on swallow response, then the effect is mainly compensatory. We are avoiding the aspiration, but not changing swallow physiology. We also are interested in the second pattern of Mataro output related to deglutition, that is spontaneous swallowing frequency, and we discovered in many studies that this pattern is affected by aging and many neurological diseases associated to oropharyngeal dysphagia. And thank you, Charles, for showing this recent picture that we have published last month in dysphagia. The message is that we discovered that oropharyngeal sensory function is critical for a normal swallow response. And if oropharyngeal sensitivity is disturbed, the motor pattern will fail. We also discovered that the central pattern generation can be also modulated by sensory inputs, and we can measure the integrity of the sensory network by using pharyngeal sensory evoked potentials and the motor cortex by using pharyngeal motor evoked potentials. This is an example of one of our studies in this particular case in patients with post-stroke oropharyngeal dysphagia. Pharyngeal sensitivity is impaired. Also, the motor evoked potential is impaired, and both contribute to impaired swallow response. Sensory impairment and motor impairment acts in combination to impair the metrics of the biomechanics of the swallow response. If you understand the neurophysiology, you can predict where you can provide treatment, because now we can stimulate the sensory side or the motor side through non-invasive brain stimulation strategies or some strategies that I will present you just now. To do that, let me introduce the Nobel Prize of Physiology of the last year. This gentleman is the Professor David Julius from UCSF. This one is Arden Pataputi, and were awarded by their work, their discoveries of receptors for temperature and pain. In particular, Professor David Julius was the one discovering the TRPV1 receptors. I'm a fan of these studies, and he also characterized several natural agonists to stimulate the receptors, such as acid or capsaicin. This is a chili pepper or heat. And Dr. Julius' lab also discovered other family of receptors, TRPV1, TRPA1, TRPM8. A1B1 can be stimulated by capsaicin, A1 by piperine, M8 by menthol, and he published he received the Nobel Prize. And that's me in Julius' lab, and this picture shows him in my lab, because I'm interested to understand the role, the potential role of real receptors in managing patients with swallowing disorders, because we study for many years the location and expression of TRP receptors in the human oropharynx and larynx. And what we found is a wide expression of the center of these receptors through the sensory fibers in the human oropharynx and larynx, and also the epithelial cells. And we hypothesize that the stimulation of these receptors through natural products could elicit a sensory response or stimulate the epithelial cells and the release of second messengers such as substance P and CGRP that could stimulate and sensitize these sensory fibers. We demonstrated this in vitro using human tissue, and we jump to clinical trials checking different natural agonists for these products and exploring through video fluoroscopy and neurophysiological studies their therapeutic effect on patients with oropharyngeal dysphagia. We use always the same experimental design. First, a series of bolus with increasing volume at medium viscosity, 300, and then two experimental series where we added the TRP agonist into series of bolus of increasing volume. We tested all these 10 different agonists, B1, A1, M8 combined agonists, to try to explore what is the best one for a patient with oropharyngeal dysphagia. And we compare the therapeutic effect with the strong therapeutic effect that show the thickening agents. And what we found is that the the therapeutic power of these stimulants is as strong as thickening agents. But the main difference is that only these TRP agonists, in particular capsaicin, can improve the physiology and can shorten the time to laryngeal vestibular closure. In comparison with the therapeutic effect of thickening agents, this slide shows the effect of pharyngeal stimulation of a patient with oropharyngeal dysphagia with TRPV1, capsaicin. This is the control situation. That's a penetration using 250 millipascals. And at your right, you will see that the penetration will disappear, and this is because the improvement, the shorten in time to laryngeal vestibular closure. We also explore spontaneous swallowing frequency, and spontaneous swallowing frequency is decreased in patients with oropharyngeal dysphagia, in particular elderly people and patients with post-stroke oropharyngeal dysphagia. And again, if we stimulate the oropharynx with a bolus supplemented with capsaicin, the spontaneous swallowing frequency increases, clearly showing that sensory inputs also affect the activity of the central pathway generation in the brainstem. Finally, we also prove that supplementation with capsaicin improves neurophysiology, shorts the first peak of pharyngeal sensory evoked potential. And if you do this in a subacute study, and this is a stimulation for 2 weeks with 1 shot of capsaicin before each meal, you can even develop some kind of brain plasticity that is correlated with improvements in midterm on laryngeal vestibular closure. Therefore, in conclusion, ladies and gentlemen, as you know, oropharyngeal dysphagia is a condition recognized by the World Health Organization and included in the International Classification of Diseases, and patients have the right to be diagnosed and treated according to the state of the art. The second is that there are 3 main steps in the diagnostic pathway, and we have new evidence of the massive screening using artificial intelligence and machine learning. We have nice tools for clinical diagnosis and very nice and modern tools for instrumental explorations using video fluoroscopy, FIS, high-resolution manometry impedance, and neurophysiology. And we now understand much better the pathophysiology of the disease, and we know that the impaired biomechanics of the swallow response is mainly linked to delay in laryngeal vestibular closure, and laryngeal vestibular closure is a critical event for safety of swallow and must be improved if you want to improve the safety of the deglutition. And we also know the characteristics of the impaired neurophysiology, and we know that the integrity of the pharyngeal sensory function is critical for a safe swallow. Finally, we have new elements for new treatments. We know that the new generation of thickening agents, and I emphasize the need to provide the viscosity of these products by using units, international system of units, according to the scientific method and the International Committee of Medical Journal Editors. So please provide the shared viscosity of what you provide to your patients. And finally, I believe that we are in exciting times and the beginning of the development of pharmacological treatments with 3P agonists and other non-invasive brain stimulation strategies, and therefore we are starting an era from compensation to the recovering of brain and swallowing function. I thank you for your attention. This is the master that we have for swallowing disorders at our university. We run this every year, and this is our new book on swallowing dysfunction in older people. Thank you very much for attention, and please.
Thank you for that extensive overview. It's amazing the amount of work that's being done. Do we have any questions? Everyone's convinced.
I guess the really pressing question is, I mean, if it's as simple as eating a hot curry to stop, or how powerful is this stimulus? Is this almost a subliminal thing that can affect, or is it really, you notice
the pungency, but we are now even trying to use TRP agonist without pungency, because we don't know if you need the pungency to elicit the neural response. There is one compound from Japan that we are trying to reach, because it's patented and protected, to just stimulate the receptor without causing the sense of pungency. So I will tell you in the next Ascona meeting.
Can I ask one quick question? When you're screening for dysphagia, is that just with medical records that you already have?
Yeah, it's working at our hospital.
Yeah.
Every morning we screen all the patients, and the nurses having read the ones that should clinical exploration.
And that's data extracted from electronic medical records.
Yes.
Yeah, exactly. Very interesting.
Yeah.
Amazing, actually. All righty.
Thank you.
Should we move on? Our next speaker is Dr. Ashli O'Rourke, who's coming from us from the Medical University of South Carolina in the United States. And actually, let's get this to, yeah, there we go. Voila.
Thank you. Thank you for the invitation to come and speak to you today. And I am really honored to be up here with so many people with an amazing background and data. I do have some disclosures. There's a relevant disclosure that I am a consultant for Laborie. However, the content of this talk was not influenced or visualized by any of my sponsors. We're going to talk about, basically very quickly, try to make up a little bit of time, the principles of exercise rehabilitation in the context of dysphagia therapy. I was a speech language pathologist in my former life before I became a head and neck surgeon. So I'm going to come at this from those two standpoints for you today. Also then transition into the utility of using high-resolution pharyngeal manometry as a biofeedback tool, and also show you some case studies as well. This presentation is going to have faces and videos with voices of patients. I don't mind if you take pictures of slides, just not those, because we have written permission to reproduce this for you as a training, but we don't have permission from those patients to then distribute it on the web or other things like that. So just please be respectful of patients' confidentiality. So why do we need biofeedback? Swallowing produces a very limited external movement patterns, and it's very difficult for both patients as well as for clinicians to really produce reliable and reproducible swallowing function in patients. Some of this is due to intrinsic feedback mechanisms that are likely impaired during the state of dysphagia. So guidance and feedback are heavily influence improve performance. And so we can't provide that guidance as a clinician. And if the patient themselves is not receiving feedback because of their disease state, then we're kind of at a loss of moving forward in rehabilitation. And now biofeedback can take many different forms. We use what's called biofeedback. So we use the laryngeal endoscopy to be able to give some feedback during swallowing. Submental EMG can be used. But what we're going to talk about today, and we use those in our practice in our biofeedback program, what I'm going to talk to you today is the use of high-resolution pharyngeal manometry for this. The targeted interventions need to be patient-specific. And so what I really want to get across is that the shotgun approach to somebody that comes in and they have dysphagia and they get the laundry list of rehabilitative strategies. We put everybody with a chin tuck. Everybody gets an effortful swallow. We teach everybody the Mendelssohn. You are not going to get the results that you would like if you don't target that intervention to that patient's individual problem. And I think we saw a lot of that in the work that was presented today. There's a diverse range of pathology that a patient with oropharyngeal dysphagia can have. It also depends on the patient too, their cognitive status, their visual abilities, the patient and caregiver experiences or preferences. And this needs to be evidence-based. Our targeted interventions need to be rooted in the literature, but also you can use your expertise too of what works with certain patient populations. And importantly, it's based on the observations of pathophysiology that we see on another instrumental examination. And so in our practice, that's usually video fluoroscopy, although we do a lot of simultaneous FEES, flexible endoscopic evaluation of swallowing, with manometry. So we join this in some way in our program. The real point of any exercise is that you do a targeted intervention and you identify that minimal dose that's needed for a biological or a physiologic change. And so these determinations of dose, and this is from Kreckler's work, is that you need to see what intensity, so you need to prescribe the intensity of the patient, how hard are they gonna work? How effortful is that swallow? The repetition, how many sets are they gonna do? Are they gonna do 10? Are they gonna do 20? And then how many times a day and how many times a week? Now, if I want six-pack abs, I'm going to need to go to the gym every day and do 3 reps of 20 apiece, or maybe I can go 3 times a week and get the same outcome. And so, especially in a disease state, we need to look at that dosing. Because what happens is that you can get a positive effect from exercise, or you can get a negative effect from exercise. And so when you want to be is in this optimal zone here, where the dosing is helpful. But at some point, you're going to start to get diminishing returns because you have fatigue. And at some point, it actually becomes harmful to the patient. And so what we want to do is we want to kind of target this area right here. We're working maximally, getting the maximum benefits. We're not moving into diminishing returns. How do you do that as a clinician? How do you set dosing? Well, one of the things that biofeedback can be very helpful for, especially high-resolution biofeedback, is to determine that. So I'm going to show you a little bit about that and how we go through it. There is a precedence for high-resolution pharyngeal manometry. Anorectal biofeedback for fecal incontinence has been around for a while. Volitional control, Dr. Nativ's work has shown that, that you can relax the UES. And then in one patient a while ago, there was a patient that they used tightening of the LES in a patient with reflux. It's really the increased number of sensors when high-resolution manometry came to the forefront that gave it the potential for feedback in the pharynx, because now we had these topographical pressure plots that had a really nice visual perceptual gestalt for a patient. I'm going to go a little quickly through some of our biofeedback program that uses manometry, but we did publish this work with my partner, Kate Davidson, in ASHA Perspectives, and so if anybody wants that article, I'm happy to share that with you if you want. It actually has all of our forms and things that we go through. So there is the right candidate for HRM biofeedback, and I speak about this topic a lot, and I know that people think that we sit around and we do HRM all day and we treat patients with this. It actually is a lot more individualized than that. We have patients with a broad range, some that receive biofeedback and some that don't, because you have to have the adequate cognition and vision to see the topographical pressure plots. And we had a patient who was colorblind, and it was really difficult for them, even though they were a pretty good candidate otherwise. There has to be no contraindication to probe placement, so pharyngeal stricture or other skull-based surgery. An ability to tolerate the catheter, so the patient that when you go to just do a laryngoscopy is backing up and backing up and backing up, or flinches the second you touch their nose, probably not going to be the best candidate. But you'll be surprised at how many patients do tolerate this extremely well with the smaller catheters. And then you have to have some observable degree of pharyngeal contractility. I'm going to show you a little example of what I mean by that. So this is a patient with neurosarcoidosis, and hopefully it will play. Let's see if I can get it to play here. Oh, I can see it right here. Sorry. Move myself around. I can't see it here, but I can see it there. Ah, there we go. I'll just put it where I think it is. Well, I'm going to show. Do you have it?
Maybe if we.
I'll go out. Yeah, here, try that.
That's weird.
Oh, it's right there.
Ah, it's
Right here. Yeah, there you go.
Yeah.
Okay. Oh, I'm going to tell you that there is no observable. I will get that. Hopefully the rest of them will work. I have it on here if not. And so there's no observable, this is a patient with neurosarcoidosis, and so we can't see the pharyngeal contractility, so they're not going to get anything out of that. Now, our biofeedback protocol starts with topical anesthesia, and this is something that is a little bit of a controversy. We use nasal anesthesia, not pharyngeal, so we put a nasal swab within the nasal vestibule, and that is wrung out so that it doesn't hopefully provide pharyngeal anesthesia, but we find the nose is the most uncomfortable portion of this. And then catheter placement, acclimation, calibration, baseline swallows, and then targeted treatment. And I'm going to show you briefly this patient here. We're going to see if it'll play now, because that seemed to work better.
This is the catheter, and what you'll see is that when we apply pressure, it shows up on our screen there.
Right.
Okay. So red is high pressure, purple is the highest, and that nice blue color is no pressure. Okay, so the absence of pressure.
So what you're seeing is just basically the clinician going through training the patient. And so this is an educational type intervention where we're not only talking about the patient and their strategies, but also swallowing physiology, and they understand it in a way that's actually very interesting. And so if we look at the patient here, we're going to place the catheter, and then she's going to demonstrate that for her, and we'll see this in a little bit more. We do talk to them about the manometric regions. So unlike swallowing physiology, where it might be a little bit more difficult for patients to understand from video fluoroscopy, where they get a MBS, then they go in a modified barium swallow, they go and see the clinician gives them their strategies to do, or they give them their exercises. Well, there's a really disconnect between what's happening in the video fluoroscopy suite and then what I'm being told to do in the clinical suite, because as a person who isn't involved in deglutition, I don't know about that physiology. So what we do is we actually teach them. We don't teach them the names like the velopharynx, mesopharynx, but we talk about the A region, the B region, the C region, and the D region, where there's dysfunction is, and we teach them this target pattern, that this is a normal swallow. How does their swallow different? In what region does it different? And then how will they then affect that swallow using a biofeedback tool? So interventions are based on the pathophysiology to start out with. But what we do is we move through maneuver and strategy planning, and this is where we're talking about compensation. So we're not trying to repair their impairment. What we're trying to do is adapt to their impairment. We also go through training and acquisition, where we're retraining them. We're improving the safety of the swallow. We're trying to improve the physiology. And then we go through dosing. And I'm going to give you examples of all of these. So this is a patient who we're going through strategy planning. And I tested all my videos before, and of course they're not working now. So this is a patient, I'm sorry, let me see if I can.
Yeah, that's right.
And I tested these all and they were working. Give me 1 second to look to see if I can find my downloaded file. Is this the one that I downloaded, the one that I downloaded here this morning? Apologies.
The one that you downloaded?
The one that I downloaded,
okay.
yeah.
Wait a second.
I think maybe just the wrong one got opened.
Possibly.
Because that's,
that might be,
yeah.
That might be the one. Okay. Sorry.
Right, because they're all MP4s, so they should play.
play.
It doesn't need QuickTime.
It's a very big file. It might take a bit.
Yeah.
Double click on it.
Okay. Let's see. I apologize. I looked through these this morning to make sure that they would play, but for some reason they are being. Is there any chance I could just put my laptop into here?
Try the
Right.
next one.
I'll try the next one. And we'll go from there. Yeah.
Some of them.
So basically, we're looking at strategy. I think it'll be okay. So basically, we're looking at strategy planning, where what we do is we look at the patient's baseline status, and then what we say is, does a head turn work best, or something like that. Then what we do is we do training. So first we do strategic planning, then we'll do visually guided acquisition. And so the first thing is to train the patient on what they're doing. So I'm going to let this play for just a little bit. This is Casey Miller, and this is this patient's first session. He is learning to do a Masako, a tongue hold maneuver.
This is our first one with the tongue out. Mostly blue, dark blue, a little bit light, and a little bit green. Let's see if we can get a little bit more color. Okay, so more effort without tensing your face muscles. Okay?
So the nice thing is
So we
she's
want
getting
brighter
feedback,
orange, yellow
and
color,
he's getting
some
feedback.
green. What did you just do there?
Okay, so yeah, and you can't hear his wife in the background, but she's in the background too. So the nice thing about this is it's everybody's getting feedback here. He's getting it. He's watching. The clinician notices when he doesn't do it wrong, because if he says, "Hey, I'm doing my Masako," how do you know? maybe they are, maybe not. And this gives really good feedback. This is his training with an effortful swallow. So when we look at it first, you can see this outflow obstruction that gets created when he starts to do the effortful swallow. By trial 8, we're a little bit better. We're recruiting more here. He's doing a lot of velopharyngeal contraction. And then by trial 12, this is an actual how an effortful swallow should look. He doesn't generate that outflow obstruction at the UES. He increases those pressures. And so it's a really nice way for the patient and the clinician. And the patient at this point can say, that trial 12, okay, this is what it feels like when I do my effortful swallow in a correct way. So when they go home to do their exercises, they're doing it in that target pattern. Now, oftentimes they don't pick it up in the first session. That we do 1 session a week with manometry, and we do the other sessions without manometry. But it's a way for us to kind of gauge and the patient to understand that. This is really helpful. This is when you get these indicators of fatigue. So when do you start to tire? When's that bullseye optimal dose? Well, this is a patient performing a Mendelssohn maneuver. So you'll just have to trust me if you haven't seen a Mendelssohn maneuver on pharyngeal manometry. This is what it's supposed to look like. Where what we do is we have that sustained pharyngeal contraction. We're trying at the point of maximum hyolaryngeal elevation to kind of maintain that elevation, and then we relax the swallow. It's supposed to increase UAS opening as well as increase pharyngeal contractility. By trial 6, the patient starts to fatigue, and you start to see that because they get this little gap. They're not getting as much. They're not getting as much contractility. By this time, trial 10, they are phoning it in. They've done a swallow, and then they just contract their muscles. All right, so this is not a Mendelssohn. This is just, I'm going to swallow, and now I'm just going to bear down with my throat. So they have fatigued by about trial 6 is when they're starting to. So when we talk about repetitions, we're not going to do 20 repetitions, 12 repetitions. We're going to do 6 until they build up the strength to be able to then go forward. And so it's a nice way of us being able to see that. I just have one case study and then a very short blip of another one. But we'll go through a patient with dysphagia with cervical spine surgery. I'm often asked a lot what patients benefit from biofeedback, and there's a whole range of patients that do. Patients with ACDF tend to do very well because of their decrease in sensory input, and so they're a patient population that we've been very successful with. Early radiation-induced fibrosis, but not late fibrosis. Patients with stroke, Parkinsonism, we've been able to do a whole range of patients to benefit from this. And this man was a 66-year-old gentleman who had a 2-month history of dysphagia following his anterior cervical spine surgery. And he had lost 28 pounds. He was unable to get food past his throat. He had a modified barium swallow on day 14, and it was so severe that they did an MRI because they thought he might have had a stroke, and he also had a gastric tube placed. And so he had a really severe impairment. Now, a lot of people have dysphagia following anterior cervical approach spine surgery, but it tends to be more in the mild field, and it tends to improve over the 2 months post-op. So it's unusual to have at 3 months still have such a severe pathology. However, he had been receiving home health therapy 2 to 3 times a week at home, and he had also been doing his exercises every day, multiple times a day. His wife did them with him. It was so cute. She must have the best oropharyngeal swallow of anyone because she was like exercising it every day with him. And he was really in tune with this. And so what we see from his video fluoroscopy is we see his simultaneous video fluoroscopy, we see all of this residue here in the inferior pharynx with relative UES outflow obstruction. But if we look at his manometry, there is dropout in the hypopharynx. And that dropout in the hypopharynx, first of all, you check to make sure you don't have your sensors out. It's the first thing to do. But this persisted over this several weeks and several different manometry sessions. And what it was we gleaned that it was probably a plexus injury from retractors because he had a single level ACDF here, and he was not a redo, although he did have a revision surgery. So this is what we decided to do with this gentleman. Because of his decreased sensation, his difficulty correctly implementing the exercises, we went to a strength protocol. He continued in PO, but he did have his therapeutic feeds. And here he is, and you see him being engaged in watching. You see him being engaged in watching the video.
All right, let's do another. Keep going. I see you working for it. All right, remember, when you do these, keep your chin relaxed. Because we're practicing swallowing. You don't eat your spaghetti like this, do you? No.
No. So you see he's not miserable. And this is his video manometry at 6 weeks. And so now we have that hypopharyngeal contractility doing very well, and PEG was removed. I'm going to skip the temporal training just to say that it can also be used as a skill training. Not only strength training, but skill. This is a person with a simultaneous swallow. And then here we just worked on relaxing their swallow, and it went from something that was very aberrant to something that was good. This is my last slide, and I'm just going to let you hear him, and then I'm going to end. And hopefully.
At what point did you decide, okay, I really want to try working on getting my swallow back?
I almost didn't.
Yeah.
I almost said I'll just stay on my feeding tube, but I think it was because I wanted to taste food again, and the feeding tube, I wanted more, basically. Yeah. So I just told myself that I needed to try to start.
Okay. And what did you start out with therapy?
With therapy? Started with the microphone.
This patient has oculopharyngeal dystonia.
Okay.
And I was swallowing like I was trying to swallow, but it wasn't comprehensive to me, and I couldn't really mechanically see what I was having to do to improve on that.
Okay.
So I was kind of at a standstill, if you want to call it that.
So you did the EMG for a few sessions, and then you tried the high resolution manometry. So
Right.
Tell me a little bit about that.
That was the changing point in me because I'm so mechanical, and I started to see my pressures instantaneously.
Okay.
Really, and I was seeing what muscles, to me, I had to move, and whether it's hold the neck back or turn to the side or what the best procedure was.
So that's just one example. We've used this in well over 100 patients, and so it can be a very effective tool for all the reasons that we discussed. And I do have to give credit to my partner for over the past decade, and to Kate Davidson. Without this, it would not be possible. Thank you.
Okay, in transition, we do have to finish up here pretty quickly. I'm not sure there's any questions, but let's get Peter up here. Obviously, you can grab Ashli at lunch. Let's see, that's not you. Okay, you gotta be right. C-bomb. Alrighty.
Yeah, sure. So the next speaker is Peter Wu from St George Hospital in Sydney. Also collaborates extensively with Prince of Wales Hospital in Hong Kong, and we'll be speaking about Cricopharyngeal peroral endoscopic myotomy, or CPOM. Thank you, Peter.
Okay, thank you very much for this great privilege to come and share some of the work in process. It is certainly preliminary, so I will not draw any grand conclusion or recommendation. And in fact, I'm anticipating some challenging questions today. But hopefully you find this work to be interesting and we can have a discussion about this. Now, before I talk about CPOM, I think I'll take a step back. Now, my mentor, Professor Ian Cook, had told me on multiple occasions that the best way to do a fellowship is just to sit there, read as many papers as you could, and daydream about until you come up with research questions of your own. So that's what I did. Couple of years ago, I was fortunate enough to I did a fellowship at Prince of Wales Hospital in Hong Kong, and during that days of just sitting there reading, I came across a paper from Ian Cook, actually from 25 years ago, that looked at the upper esophageal sphincter dysfunction in Parkinson's disease. I thought that was very interesting, so I dived into it a little bit. So we know that Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's disease. And in fact, there was a trajectory study that estimated there will be about 9 million people living with Parkinson's disease in a couple of years' time. Virtually everyone with Parkinson's disease do develop a degree of irreversible dysphagia at some point of their disease course. And not only that you can't swallow, aspiration pneumonia have been shown to be an important cause for mortality in these patients. Now, we all know that oropharyngeal dysphagia in Parkinson's is just like any other neuromyogenic disorders, there are multiple pathomechanisms involved. But of them, importantly, there was a EMG-proven upper esophageal sphincter dysfunction. And a little bit more about that. So during that year, we looked at 60 consecutive patients with Parkinson's disease, and we analyzed their swallow metrics using swallow gateway. We found that there was a very significantly increase in the USIRP and hypopharyngeal intrabolus pressure, suggesting that there probably is a restrictive pattern here that we're seeing. So this is important because it provides us with a potential treatment target. How do we go about this? Now, there have been case series about transcutaneous form of cricopharyngeal myotomy, and if you look at those case series, it does seem to work, but it is often, because of the invasiveness of this procedure, it is often associated with very significant mortality and morbidities. In my part of the world, our ENT surgeons do not like to perform this type of surgery, especially in a group of elderlies who are already frail to begin with. So it is clearly not good enough. So I was thinking, can we do this? Can we achieve the same surgical goal but using an endoscopic approach? Now, many of you will be very familiar with this drawing, peroral endoscopic myotomy, or POEM, introduced to us by Professor Wu in Japan about 12 years ago. And since then, it had really become a first-line treatment of choice by many clinicians as a treatment for achalasia of the cardia. I thought to myself, can we just borrow that endoscopic concept, but now instead of treating the lower esophageal sphincter, we can use it to treat upper esophageal sphincter dysfunction. That's all that there is. So we did a very small pilot study. We recruited a group of Parkinson's disease patients with self-reported dysphagia, and more importantly, there need to be a demonstrable upper esophageal sphincter dysfunction. And as many of the speakers today had already alluded to, the IRP seemed to be the most discriminating metrics thus far in discriminating the healthy control from the one with dysphagia. We decided that the raised IRP, US IRP, was an important criterion to be included in this study. And since that this is really a uncharted water, we decided that in addition to raised IRP, we also needed to include one of the adjunct features, for example, raised IBP or reduced opening or reduce sphincter relaxation time. Now, in interest time, I will only just show you the most important result, and that was in this pilot study. We looked at we were able to perform CPOEM to completion in 8 patients, and the technical success rate was 100%, and the mean procedure time is just a little longer than an hour. But I think this will decrease as our experience grow. Now, surgical emphysema was universally observed in every single patient, and during the procedure can actually be quite frightening because the patient's neck and face will puff up. But because we only use CO2, strictly only CO2, they tend to resolve very quickly. Usually by the time that we finish the myotomy, closing up the mucosotomy, most of the emphysema was gone. Thankfully, up until now, we have not observed any significant post-op complication. There's no perforation, there's no infections or delayed bleeding. And surprisingly, that despite that we were really operating in a very high up, and the placement of the endoscopic clips were very well tolerated by all the patients. Certainly that most patients will require minimal to no post-op analgesia, and they only stay in the hospital for 24 hours. In fact, in this particular pilot study, because we were dealing with the dilemma of whether to give them their Parkinson's medication immediate post-op or not, they're risking they're being locked in with their symptoms. So we actually initiated the medication pretty much as soon as they came out of sedation. And they're all very well tolerated. I will show you some of the results from this study. Now, we looked at the patient-reported outcomes using two questionnaires, Sydney Swallow questionnaires that have been mentioned several times this morning, and also another validated SWOCO, which is a swallow-related quality of life questionnaire that had been validated in Parkinson's disease. Now, if you look at the graph on the left, you show that even though that we have only very small cohort, 8 patients, there was a demonstrable improvement with in their swallowing symptoms with a decrease in this, the SSQ score. And I will emphasize that because there are multiple pathomechanisms involved in a dysphagia, so unlike the treatment of achalasia, we don't see complete normalization of the swallowing function. The restoration of the swallowing function is partial. But I think it's also still quite encouraging to see that we can still see the same trend of improvement in the swallow-related quality of life. What about objective measurements? So we repeated the pharyngeal manometry with impedance 1 to 2 months after the CPOEM. Again, you can see that with the IRP, there was a very clear improvement in the reduction in the IRP, and the intrabolus pressure was also reduced significantly despite having a very small sample size. So in summary, CPOEM, at least it seems feasible, and so far it seems safe. Even with a small sample size, we could demonstrate an objective improvement in the pharyngeal manometry metrics with the IRP and the IBP. And from a patient-reported outcome viewpoint, there also seemed to be improvement in the swallowing symptoms. Now, again, I will say that this is a very preliminary pilot study, so I don't want to draw too much conclusions. So there are lots of important questions to be asked. So we have just recently launched an RCT comparing CPOEM with a standard therapy. Please watch this space. Hopefully that I will be able to present the study, the result from this study very soon to you guys. Now, is there a role for CPOEM as a treatment for other neuromyogenic disorders that manifest EU as dysfunction? I will finish my talk with a very quick study. Now, this is a 63-year-old man who was referred to our clinic a couple of years ago. Now, before that, he already had a lateral medullary stroke 3 years before presenting to our clinic. And as with most lateral medullary stroke, this patient had a very long recovery time, needed tracheostomy for 12 months. By the time that he saw us, the tracheostomy was already removed. Now, this guy was wheelchair bound and he had profound dysphagia. Not only he was completely PEG dependent, he could not tolerate his own saliva. So he came in with spit bag and spitting out his saliva every minute, trying to have a conversation with us. So naturally, the quality of life is really restricted because of the very profound dysphagia. We did a high-resolution pharyngeal manometry on him, and morphologically speaking, you can see that this guy has a reasonably well-preserved pharyngeal contractility, but the upper esophageal sphincter did not seem to relax with swallowing. And in fact, when we measured objectively, the IRP was definitely raised above the normative range. So we offered him a CPOEM. I'll show you a quick edited video. The first thing you're going to see that is we start the procedure quite high up in the hypopharynx. In fact, you can see the endotracheal tube here. That's the epiglottis, and this is a posterior laryngopharynx, which is where we did the procedure. So as with the poem, the idea, the endoscopic principle is exactly the same as poem. We started the mucosal bleb, submucosal bleb with the injection in the hypopharyngeal wall from posterior approach. And once we've completed that, the next is to use a needle knife. In this case, we use a triangular TT knife to create a 1.5 centimeter mucosotomy. Now, this part can be a little bit tricky because you obviously don't want to damage the larynx in front of you. But once you've gained access into the submucosal plane, the remaining procedures is more or less same as a poem, but the length of the tunnel was much shorter because as soon as you get into the hypopharynx, you're pretty much the CP muscle is right in front of you. So you don't really need to create a very long tunnel. The tunnel is usually about 4 to 5 centimeter. And CP muscle can be quite easily identified at the time of the endoscopy, and you can see that there's constricting effect that's quite typical of both the CP muscle as well as the lower esophageal sphincter. And once you've finished creating the tunnel, then you perform the myotomy using the same needle knife. The myotomy length, again, it's not long because it's usually about 3 to 4 centimeters. That's more than enough. And we can usually identify the upper border of the sphincter muscle quite easily because not only has a constricting effect, you can also see the changes of the muscle direction from an oblique orientation of the inferior constrictor to the more horizontal fibers of the cricopharyngeus. And as you can see that once the myotomy goes beyond about 3 centimeters, the muscle thickness starts to thin out, telling you that you're now in the cervical part of the esophagus. Then you can stop the myotomy because going further is not going to help, I think. And once that's finished, we will close the mucosotomy with a series of endoscopic clips, just like we do in poem procedure. Now, this part can be a little bit harder than the standard poem, and this is actually something that I've just recently learned as I was Googling the hypopharynx. Because I was bored, and I learned that there's different to the rest of the GI tract. The hypopharynx doesn't actually have the muscularis mucosae, so that makes it the tension that reduces the tension on the opposition of the mucosa when we try to close it. That makes it a little bit harder. But overall, it's the same endoscopic principle, just in a different sphincter. So for this patient, we tracked him longitudinally, and you can see that at the start of when we did the C-poem, his SSQ score was virtually maximum because he wasn't eating and drinking anything. A couple months later, he stopped using the PEG altogether. And then about a year later, he decided, that's it, I've had enough. I'm not using my PEG for anything at all, not even water, medication. And we waited for a year before we decided to agree to let him to have the PEG taken out. So I think that does create a big improvement in his quality of life. Upper esophageal sphincter manometry, you can see that after this is the post-op manometry, you can see that we definitely pinged the right muscle with the myotomy. And you can see that the IRP also reduced to within the normative range. And in addition to Parkinson's and lateral medullary stroke, we had also been looking at using C-POEM as a treatment for other neuromyogenic disorder manifesting US dysfunction. And these are some of our unpublished data at the moment. Quite interestingly, that I think that potentially patients with inflammatory myopathy, with IBM dermatomyositis, they can also gain quite a significant improvement in their swallowing function. Again, I think that we will never see complete restoration of the swallow function. The improvement is always going to be partial because of the multiple mechanisms involved in dysphagia in this population. So at risk of C poem being a Me Too type of poem, I think that I want to just emphasize that I think that the potential burden of the cricopharyngeal achalasia, for lack of a better term, is quite significant. I mean, for Parkinson's disease alone, we're looking at 9 million people living with it in a couple of years' time, and virtually every one of them will develop dysphagia at some point. And this is before we start exploring the potential of C-poem as a treatment for other neuromyogenic disorder, also manifesting US dysfunction. I think there's an important potential for this procedure to improve the quality of life. So with that note, I'll finish my talk, and thank you for your attention.
I see one question back there, and I'm sure Mark has some announcements about lunch. Can we back?
Thank you. Again, Mario Costantini from Padua. I have a comment, wonderful presentation. I have a comment and a couple of questions, quick. The comment is that open transcervical myotomy has a mortality, as you've shown, but mortality is not related to the invasiveness of the procedure, but the patients are very frail, they are old, so this is not. But I agree, poem maybe is the way to go. The question is, one, why you choose to call this procedure C-poem? Couldn't you stick with the Z-poem? Because now we have a C-poem, Z-poem, D-poem, probably we have A-poem for achalasia, so that could be confused, first of all. Second, the length of myotomy, you said that 3, maybe 4 centimeters, but we know from back studies that the sphincter must be, sometimes is much longer, because it's not only the cricopharyngeal muscle, but also the cervical muscle of the esophagus. And finally, the most important is the final. In achalasia, there is only one way. The pharynx is a 4-way street. Yes, I'm a big fan of Crosby, Still, Nash, and Young, but 4-way street. So the problem is to identify one way that is not functioning, the sphincter, but the other should be quite good enough to prevent aspiration and so on. So the question is, you partially answered with the beautiful manometry that you've shown. Have you ever thought to try and make some Botox injection to see if the patient respond, and then to select patient that can undergo the poem procedure with enough good results?
Okay, thank you. There was I'll try to remember all the questions.
Can we just stick to the last question?
Stick to the last question. Okay. The last, yes, I think Botox injections remains a valid treatment for US dysfunction. Now, I also, within the cohort that I showed you, there were a couple of patients who had previous Botox injection with short-term therapeutic response. So we then offered them a C-poem procedure. The problem with using Botox as a blanket guide for the C-poem decision is that Botox will create a lot of submucosal fibrosis. And just like with the poem here, it can increase the fibrosis. And up here, that even though in those patients I was able to complete the C-poem, I could definitely see there's submucosal fibrosis, and this is a much tighter space to work than here. So even just a little bit of fibrosis can potentially make the procedure difficult. But I'm not saying that this cannot be done.
Thank you very much.
Great. Thanks, Peter.
Well, thank you very much, chairs. Thank you very much for the speakers. A fantastic run through pharyngeal